primary hospital before coming to our center. The other challenge we are faced with is that the absence of a coronary care unit and the absence of an emergency unit. We thrombolize our patients in the ICU. The ICU only has 4 beds. We have a high dependency unit also, which only has 4 beds. And this ICU, it serves for our post-op patients, and it also serves for very critically ill patients in other parts of the country where they can't be properly managed. They also bring them to our ICU. So sometimes patients come, they're within the time when fibrinolytic agents can be administered. They sometimes even can't afford to go ahead. And yet, because of lack of space, we're not able to do the reperfusion therapy for our patients. Again, we don't have an emergency unit, and therefore that also is a reason possibly why some of our patients delay before coming to the center. The other problem that we're faced with is the lack of trained personnel. We are the cardiologists right here in our center. Cardiologists are not really being trained in our center. It's more the surgeons, they're surgical residents, so we don't have cardiology residents. So we as the cardiologists, we are very few, and we have to do everything ourselves. And the other thing too, even our nurses, because we could say we could do the thrombolysis even on the ward, but our nurses are very few on the ward, and they are not even trained, properly trained, so that we can say, okay, we can do give the services on the ward. Another challenge is the troponin. The troponin on weekends and in the nights, that's the problem. We don't do the troponins at our center, so we rely on other centers, and because of other labs to do it for us, and because of that, weekends we can get results, and after 5 usually. And there's also a delay in getting the results back at times. Cost of coronary angiography. So although the coronary angiography is available right there at our center, whenever the patient wants, they can get it, but the cost is so much that they can't afford it. So really, it's not really available to the patients because of cost. The other thing is there's no sponsor for CABG. It's easier for the pediatric patients to get sponsors because they can go to the radio stations, they can go to the TV stations, and they can ask for funds. But nobody is going to fund a 56-year-old man for a surgery. So it's very, very difficult. Most of them, if there's no family support, then they're doomed. The other problem we are faced with is that there's CI available in Ghana. And that is not so much of our problem when the patients are stable, when we can apply the fibrinolytic therapy for the patients. But some of our patients come in cardiogenic shock. And then what do we do? Because no PCI available for them. And so it's very difficult to treat these patients. Lack of supportive devices also poses a problem because some of our patients, after, for example, they even stabilize after 48 hours, maybe the 3rd day of admission, then they start up with some arrhythmias, ventricular arrhythmias. You check everything, electrolytes is okay, nothing else is the cause, and so you know it's because of the ischemia, and yet they can't afford the ICDs. So it's a big, big challenge for us. And all our challenges, well, most of it can be really summarized in the cost. Everything is about the money. And we quote in euros. We don't quote even in Ghana cedis. We quote in euros. And so it's very difficult for the majority of our patients to get treatment. And so with that, I end I think all the recommendations, you can clearly get them, so there's no need repeating. And so with that, I will just say thank you.
Now I call on Professor Bara Diop from Senegal to give us the experience of the management of acute coronary syndrome. Professor Diop.
Thank you, Professor. One of the tasks they asked me is to talk about acute coronary syndrome, but my colleague gave a very informative talk and academic talk, so I will most focus on management challenge in the West African sub-region. So this is an overview of my talk. First of all, I will give, without insisting, general consideration and guidelines about acute coronary syndromes. I will focus on African context, current possibilities and perspective before conclusion. As you may know, in the world and in Africa, ischemic heart disease will be the major cause of death, even in men and also in women. And as you may know also, ischemic heart disease, as told by Galavardin more than 50 years ago, can last 30 years old, but it can be also a sudden cardiac death. So if you want to deal with ischemic heart disease or acute coronary syndrome, you have to prepare yourself to manage very, very quickly patients. And the time is very important because time is muscle, and the objective of the management of acute coronary syndrome should be reduce size of ischemic zone, preserve left ventricular function, prevent and manage complication. And in all these goals, the time is very, very important. The principle of treatment of acute coronary syndrome has been explained by my colleague. It can be summarized on relief of the pain, antithrombotic treatment, and thrombolysis. Thrombolysis should be available everywhere in Africa and in the big city, but the big challenge is to thrombolyze in the first hour, and we have to focus our effort to make the system working and patient to get thrombolysis in the first hour. I will explain why later. And of course, management of acute coronary syndrome is based on anti-ischemic measure, beta blockers, nitrate oxygen, and to avoid also ventricular deformity, it is important to use ACE inhibitor and ARB in case of contraindication of ACE inhibitor. Stabilization of atheroma is also an objective by statin, ACE, and ARB, and also management of complications. So the system you have to set up should be all these goals. And of course, patients having antithrombotic treatment should go if there is some facilities and also an experienced team to PCI. We will see why PCI is a preferred choice, but it is not available. PCI they can get stand or covered stand, and in some case they can have clot aspiration. In some case, cabbage is mandatory. We had several months ago a patient coming from Seychelles. He had an acute myocardial infarction, but there was not cardiologic there. So the patient flew to Dakar and came the day after, with, of course, myocardial infarction. It is very important to thrombolyze in the first hour, because when you thrombolyze in the first hour, the mortality is low, so you can save 60 to 80 lives for 1,000 patients. After the first hour, the mortality rises by 50%. So if we want to manage acute coronary syndrome, you have to deal and to build system which give us the possibility to thrombolyze in the first or the 2 golden hours. Of course, emergency medical system is part of the system you have to build, because without emergency medical system, it is impossible to thrombolyze in the first hour. So, as you see, the management of acute coronary syndrome necessitates a management chain. One thing is important, is the patient delay. So, to have a short patient delay between the pain and the call, you have to educate people and to make information, a large-scale information on the population. It is also important to activate emergency medical system in order to get thrombolysis in the house of the patient or in the ambulance, and it can save a lot of life. And if possible, in the country which have facility to have rescue PCI if thrombolysis is not working, or if we are in the delay, door to balloon, to go directly to PCI, primary PCI. As you know, in STEMI, there is a complete obstruction. In this meta-analysis published by Upker in 2005, we saw in the blue line that if you do very, very early thrombolysis, you have minimal mortality. So very early thrombolysis is as effective as primary PCI. And later on, if you have a delay, of course, PCI is the better choice. So the treatment options are, of course, thrombolysis, early thrombolysis, primary PCI not available, you can have 60% reperfusion rate. Primary PCA, you have more percentage reperfusion rate, and it is mandatory in case of Kili plus 3 or 4, severe ventricular arrhythmia, fibrinolysis contraindication, and also late presentation. This study shows also the advantage of primary PCI versus thrombolysis when it is available. You see on all the endpoint deaths you have, and all cardiac event, you have beneficial of PCI, primary PCI. So if it is available and if you can get it in a short time, it's the best choice. And in primary PCA, you have a patient delay, so we can act on the patient delay, but you have also system delay. And the system delay, time to balloon, had to be less than 2 hours. Thrombolysis, of course, is available and very cheap with streptokinase, but Techneplas is also a very good thrombolytic. It's very expensive, but it is very good and simple to use. So it's not very difficult to train the nurses and to get it very quickly. What tell us the guidelines? So in pre-hospital management and reperfusion strategy, within 44 hours or first medical contact, primary PCI is recommended reperfusion therapy over fibrinolysis when you can have a delay within less than 2 hours. If not, you have to go quickly to fibrinolysis, which is also efficacious. This is a slide also for the recommendation for the delay. Preferred first medical contact to ECG should be less than 10 minutes. So someone who has chest pain, you don't have to lose time. You have to do quickly ECG. And you know also the other delays. What is our African context? As you may know, 35 countries of the 50 least developed countries are African. 70% of all Africans live with less $1, and most of the country most of the Africans don't have electricity. If you see the massive divide in life expectancy, this is data of UN. You see indigenous Australian on the right on the left-hand side, and you see Australian, white Australian on the right-hand side, and you have also African Americans North Americans and native Canadians. So there is a massive divide in life expectancy. The Millennium Development Goals, among these Millennium Development Goals, we can also highlight achieve universal primary education, combat cardiovascular and other diseases, and develop global partnership for development. In cardiology, my conviction is that develop global development partnership is very important. And UN at Midway told us that achieving the Millennium Development Goal, no sub-African country was on track to achieve this goal. And even the best governed country in the continent have not been able to make sufficient progress. What is about production on frontier knowledge? Someone talked about yesterday, but as you may see, in North Africa, you have less than 0.5% of the knowledge. Sub-Saharan Africa, less than 1%. And most of the knowledge is coming from Western countries. There is some disparity between south to south. You see Egypt, South Africa, Korea. And as you may know, Korea in 1960 has the same national gross national products like Senegal and also Ghana. They have in 1960 the same national gross product. And there is also disparities within Africa. You see Ghana, Senegal, they have the same percentage, South Africa, and Morocco, Tunisia. Morocco and Tunisia can be some example for us. We may innovate to change our scope. We have to innovate. Innovation is a process of making change to something established. It is not invention, no. And invention followed by innovation drives economic growth. This is a reality. University is good at research. From research to innovation, there is a gap, and only a few universities bridge it. Industry is good at developing know-how and making products, and geographical proximity between university and industry is a good thing, and university, private and public, play a very important role. We can have an example in Tunisia. They had a huge investment. Why Tunisia have best infrastructure in cardiology than the rest of Africa? They invest in higher education. In 2008, 1%, 1.2% of GDP was devoted to research, and they make a lot of investment. What is our position in Africa? Less than 0.3% in gross product. So in Senegal, we made some innovation because we built emergency medical system which is private and 24 hours, 7 days. And when you are in your house, you can call this emergency medical system and you can get thrombolysis in your bed because they have streptokinase. Because they have, but it is private, they have streptokinase, they have even technoplasm, so it is working. And the state 2 years ago also managed a public system, emergency medical system, but until now you can get thrombolysis by this system. And Professor Nya, which is a pioneer, has built up a cardiac unit. You see here the surgical intensive care unit, and also the patient, the pump, and we can get also cabbage. Since April, we built up a cath lab with, of course, a partnership of international partnership, and we are doing coronarography, we are doing PCI, not now